Well, hi, everyone. I think everyone that's been admitted has had a chance to connect, and we'll go ahead and get started since it's 6:04. I want to welcome you to tonight's seminar. Our guest speaker tonight received her bachelor's degree from Duke University, her medical degree from Morehouse School of Medicine, and her MPH specializing in maternal and child health policy and leadership right here at UAB in the School of Public Health. So while she was pursuing her MPH, she was also an adolescent medicine fellow with the HRSA MCHB Leadership Education and Adolescent Health Training Grant in the UAB Department of Pediatrics. And so currently, Dr. Hill is an assistant professor in the Department of Pediatrics at Emory University, and her research interests focus on all aspects of sexual and reproductive health in adolescent and young adult populations. So that makes her the perfect person to talk to us tonight about what's changed in the last 40 years when it comes to HIV in the pediatric, adolescent, and young adult population. So welcome, Dr. Hill. We're glad you're with us tonight.
Thank you. Thank you, Julie. And it's great to be back and see some people that I know. It's my pleasure to be here with you all tonight. While I get my slides up, I have to request to be able to share slides. But while I get my slides going, I do want to say please feel free to unmute yourself if you have a question. I'm gonna try to keep up with the chat. Um, but if you have a question, unmute yourself. And maybe if Ashlyn can help me if there's something in the chat um, that's imperative to be answered, please just let me know. I also am gonna try to ask you all questions, not anything that's too strenuous or crazy, but just to kind of hear your thoughts, hear your voices. So feel free to share your responses. So I am Samantha or Dr. Hill or Dr. Sam, Doc Sam, all those things are what various people call me. And I am a physician as well as a researcher. And one of the places in which I do care is HIV. So I care for young people with HIV. And so I'm going to try to blend in my clinical and my research lenses into this presentation. So it's going to be a little bit of everything today. And it's all young people. All right, so we're going to talk a little bit about the epidemiology of perinatal HIV exposure. So that's mother to baby transmission. How do you prevent that? As well as the epidemiology of HIV for adolescents and young adults, as well as some children, and prevention of HIV in these populations and opportunities that I'm doing with some of my research. So again, as a clinician, I always like to ground things in a case. And it's important for me because while HIV is definitely a global epidemic, it's important to kind of sometimes highlight what goes on in the US. I know you guys had an amazing speaker last month who had a global focus. So this month, or I guess at the end of this month, you're going to get an US or stateside focus. And these are my patients. I've adjusted some things so you couldn't tell who they are, but these are all my patients. And so, I'll have a 32-year-old mom coming in, and she's got 4 children. She's presenting with her newest child, who's only 4 weeks old. During her pregnancy, she did have a known diagnosis of HIV. Um, um, and that means that she had HIV prior to getting pregnant. She had what we call an undetectable viral load, which here in the US is going to be less than 50 or ideally less than 20 copies per milliliter. But she did have her viral load go above that for at least 3 months during her second trimester. She's been adherent to her medicine the entire time, of which she's on 1 pill once a day. And then the only other thing that happened during her pregnancy was that she had some unstable housing. And so she had to go from where she was living to live with family members with some brief periods of not having any housing at all because her home was destroyed by a natural event. Her delivery of this beautiful son was uneventful. She was full term at 38 weeks and it was a vaginal delivery. She had a normal 2-day hospital stay, and her son was started on a medication we call zidovudine, which is what we start at minimum, all of our babies that are born to moms with HIV on, the young baby had an HIV DNA obtained. So that's a lab test that we draw within the first several hours of them entering into this world. And then we'll talk a little bit about what it means to classify the infant's risk level, because what we do is we figure out, how likely or unlikely is this young child to get HIV from their mom. So they classified this infant as low risk. And then they told mom, go follow up with HIV clinic or HIV prenatal clinic. And so I'm curious, based on what I just shared with you, how many of you, and you can do a thumbs up emoji or a hand raise, how many of you think that this baby is very likely to acquire HIV from their mom? I don't know if anybody is brave enough to put their hands up. Okay, how many of you think that this infant is very unlikely to acquire HIV from their mom? No emojis? Okay, I see one. I see Ashlyn. All right. All right. So let's see what happens with this baby. And again, um, this is a patient of mine. So before we talk about what happens with this baby, I think it's important to understand that this case that I presented falls way over here on the left side of this graph. And so what you're looking at is a graph from the CDC, which are hard to come by these days, but a graph from the CDC from 2018. And it shows the diagnoses of HIV based on age. And this is for young people in the United States. So this would look very differently depending on what country you're looking at. But for the US, this is pretty general, including if you are in the Deep South versus the Northeast versus the West Coast. And so what you'll see is there's a decent number of new diagnoses, and this number has gone down a little bit since 2018, but a decent number of new diagnoses between 0 and 5 months of age. And then you've got 6 months of age to 2 years of age, not that many diagnoses. And then you can see from 2 to 12. And you might be asking, Samantha, why does this graph end at 12? Because in the United States, we define pediatric HIV as from birth to 12 years of age. If you acquire HIV, or if you're actually 13 years of age or older, 13 to 24 specifically, you actually qualify as an adolescent young adult HIV. And so it's important to understand the numbers when you see United States data. This is the age range for pediatric HIV. So this baby, they got their zidovudine within 6 hours of birth, and that's according to the guidelines. They got their HIV test immediately. And then the infant was categorized as low risk, and they were categorized as low risk because their mom, for the most part, she had her diagnosis prior to being pregnant. She had been adherent to her medications. She did have that small increase or jump in her viral load, but during the entirety of her 3rd trimester, including the last month of her pregnancy, she had an undetectable viral load on multiple occasions, with at least a couple of those occasions being 4 weeks apart. All that jargon is not important other than to understand that this baby has a pretty low risk chance of acquiring HIV. The reality of what I see clinically is, regardless if you happen to be a very low risk, a low risk, or sometimes even a high risk baby, most of those babies, if we're doing what we're supposed to be doing, which means starting them on either 1 antiretroviral or 3 antiretrovirals in the case of the high risk babies, most of those babies are actually going to go on to be normal, healthy babies without HIV. And so thankfully, we've come a long way since the 80s and the 90s with how HIV is treated. And then what happens with these babies is we test these babies multiple times over the first 6 months of their life. And ideally, we're able to, at 6 months, say, you know what, this baby can be discharged from this HIV follow-up and is actually likely to be successful and not have HIV. There are some babies that get lost to care, and oftentimes those babies get lost to care for a variety of reasons, including nobody actually linking them to care, or stigma that's associated still with HIV that may prompt the parent not to want to seek care. I have a question for you all again. Um, just in general, how many of you all think that the average pediatrician, and I mean average meaning like the pediatricians in your community that you guys live in now, or the family medicine providers in your community that you live in now, would be open to monitoring a baby that was born to a mom with HIV, just monitoring them. This is a baby that doesn't have a diagnosis, they just need some monitoring. Can you do a thumbs up if you think the providers in your community would be open to doing that? Okay, I see thumbs down. Okay, okay, I see in an X sign. Yeah, so you guys are right. There are a few providers in communities that don't necessarily have HIV training or background that are open to doing that, but you guys are completely correct. Most providers are not willing to do that. And so while we have amazing medications, we've got easy to follow guidelines to care for these young people. Oftentimes, there's an additional burden on these families because they may have a pediatrician, particularly in this case where this mom has 3 other children. She may have a pediatrician that she loves, and the newborn goes there for their care, their regular care. And then she also has to bring the child to see someone like me for a separate visit. And that can actually be challenging and lead to people not necessarily being as adherent to following up with us as we would like. So there's a lot of different challenges in this, but it's a lot, again, like the outcomes are a lot better than in the 80s or 90s, where if you were born to a mom with HIV, you likely would get HIV. Um, so I wanted to show you this, and this is work that one of your own, she's a medical student at UAB. This is Divya. She's been working on for the last, I give her credit, she's been working on this probably her entire time of being a medical student. But she is going into OBGYN, and she was interested in perinatal transmission of HIV. And she wanted to know how we in the state of Alabama, and I say we because I've been doing this project with her for a while, even though I'm not in Alabama now, how we in Alabama have been doing as far as trying to reach the CDC's goal of less than 1 in 100,000 live births having HIV. And we're getting there. We actually were there in like the mid 2000s. That sounds weird to say, like maybe in the early teens of the 2000s. But we are not there now. Um, and what the CDC has done is they proposed a framework that you can kind of see. It's a little abstract, but you can kind of see in this figure to help people achieve this goal. And so the idea is to have a way to do some kind of case review of every person that is pregnant who ends up giving birth. So every pregnant person reviewing their birth and making sure that we can link them to care, making sure that we can provide clinical and psychosocial services, not only for that infant, but also for the pregnant person and or family if they need it. Having structured and standardized ways of reporting that data, and then doing research and additional monitoring to figure out how we can make that data better and make our results stronger and make our protocols more standardized. This involves a lot of things so this is the public health side. It involves a lot of things on the clinical side too, such as, making sure that there are multiple ways for people to get HIV testing, as well as making sure that family planning options are discussed with every individual, regardless of their gender and or our biases as to whether or not they may be trying to conceive or not. So Divya took it upon herself with some help to actually develop a survey that has several different aspects of this framework in it. And she actually reached out to all 42 places where you can give birth here in the state of Alabama to see how they were doing at following these protocols. So she sent surveys out to these departments, and pharmacy being the last one. And I'm curious, do you think the majority of the responses she got were from places or from departments that were adhering to the CDC's recommendations? I see Ashlyn says no again. Yeah, I see Winifred, Dela, they all say no. So yeah, you guys are correct. We're still finishing analyzing this data, but what you can see is On the left, you see a breakdown of what happened. So there were 42 birthing centers. We only heard back from 28 of the 42 birthing centers. So we heard back for more than 50%. But we didn't hear back from everybody. And you can kind of see where they're located along the state and whether they're public or private institutions, public being they take public insurance like Medicaid. You can see that the majority of them deliver about 100 to 1,000 deliveries a year, but that, excuse me, the majority of them have less than 20 deliveries of infants to moms that have HIV. So this is not something that they come across a lot. So it probably makes sense that they may not be as aware of and or adherent to guidelines because they're probably having to go search for these guidelines every time there's a baby. What you can see on the right is a heat map that Divya created to kind of give you an idea of um, how well certain parts of the state were doing. You can see that we did not get any responses from anywhere in the southeast, any of the southeast places in the state. And you can see the people that were doing a little bit better are in Jefferson and Mobile counties, while the people that were doing a little bit worse are in, as far as adhering to these protocols, are in the southwestern and northeastern I shouldn't say counties, health district departments, health district areas. So we have some work to do with all the different places in the state. But the takeaway from this is since the 80s, we at least have medicines that the babies can use so that we're not worrying about babies passing away less than a year old because of HIV and advanced HIV or AIDS, as you all probably know it. And we have protocols in place as well as goals for the protocols. We just have to figure out better ways to actually enact them and standardize them and make them easily accessible. I do want to share some updates about breastfeeding. Who knows um what the rules of breastfeeding were maybe about 5 years ago? Anybody know what the rules for the US for breastfeeding were 5 years ago? Could you breastfeed in the US or not if you had HIV? No. Ashlyn says no. I love the emojis. Dayla says no. Okay. You all are correct. Winifred may still say no. Her no has not disappeared. So yes, prior to 2023, you were not allowed to breastfeed in the United States. Globally, you could breastfeed because of the concern about different organisms being in the water that you would use to mix formula, and those organisms being deadly or harmful to infants. In the US, we don't necessarily have that challenge. You get filtered water and such. But what happened was in 2023, based on a lot of the data that they received globally, as well as the fact that we are a country of immigrants and people from all over the world, they updated the guidelines for breastfeeding. And so now certain women have the option of breastfeeding if they would like to do so. Those are, I shouldn't say women, but people, pregnant people. So if you are a pregnant person that has delivered a baby that is full term and healthy, that's not in the neonatal ICU, that is not premature, and you as the pregnant person are actually classified at and have your baby classified as very low or low risk as far as HIV acquisition. And we as the healthcare team can track you as mom, you being mom, dad, mom, whoever's records. We can track that your records, your viral loads. You are someone that we can have a discussion with about whether or not you would like to breastfeed. Now, some things that are different between breastfeeding with HIV and breastfeeding without HIV in the US is the length of time. So in the US, we recommend that pregnant persons that are interested and desire to breastfeed for 12 months. If they can, 6 months is great, 12 months is ideal. But if you have HIV, we only recommend that you breastfeed for up to 6 months. It's very strange because the risk of HIV acquisition with breastfeeding is super high in that first couple of months after delivery, but overall it's 0.6 to 0.9%, which is not zero, but 0.6 to 0.9%. over that 6-month period. But if you go longer than 6 months, it actually increases. And so that's something that you guys should be aware of. I don't know what people on here are interested in going into, but that may be some data that you'd be wanting to look at, like how effective are these guidelines? How many pregnant persons are actually choosing to breastfeed now that they can? What I will say is the babies that are being breastfed, they are on medications during the breastfeeding process. I will also say that each institution has slightly different protocols in place. There's recommended protocols nationally, and then I think because some people are a little bit more nervous and sensitive, they may actually do something a little bit extra that may not be part of the national guidelines, but you can breastfeed in the United States. Okay. So here's my second case. This is another patient I had. And this is just touching on pediatric, like child HIV. And this is an 11-year-old young man who had perinatal HIV, who has moved to the state and is now living with dad. So they present as a new patient with dad. Dad doesn't have any of the medical records. Dad does know the young person has HIV, and he has 2 bottles of antiretrovirals in his hand, which means you have to actually look and read and hope that there's a label on these bottles. I'll tell you, in real life, this patient, this case is modeled after, had 2 pills in their hand. So I had to go on Google, and they moved here from a different country. And I had to Google the pills in their home country to see if I could figure out what they were. But for the purposes of this case, this person is in 6th grade and they want to be a SpaceX explorer. They're loving SpaceX. They are not dating, which is not uncommon, right? They're 11, but you never know. They're not interested in dating. They think girls and boys and everybody is because they are annoyed that they had to move. They're not using any substances and they don't have any concerns as far as mental health. The young person is taking his medicine, and you are thinking about the fact that it's going to be super challenging to have him take 2 pills a day because he's 11. And right now he has dad helping him. But when he's a teenager, he's probably going to do that on his own. So you're trying to figure if you can make him have a 1 pill once a day regimen. And again, these are like real things. So let's talk a little bit of, again, a refresher about pediatric HIV. And so he's 11. So he's at this tail end of what we call pediatric or children with HIV. You can see that when we're looking at children with HIV, and again, save any data you guys have, because sometimes right now you're not able to find newer data. So save the data in the slides that you have. Always archive those. But you can see, if you look, the green is the percent of the population, and then this purple fuchsia color are HIV diagnoses compared to the population. So you can see that at least for pediatric HIV, Black and African Americans are disproportionately affected, followed by individuals from multiple race as well as Asian Americans. So, oh, there we go. So a couple of things to think about with this age group. This child is 11. And in the process of me trying to think about how I can simplify his regimen, I also have to think about, does he actually know his diagnosis? Here's a question, and you can maybe put it in the chat. I don't know if I can see the chat, but someone, if they're brave, they can come off mute. How old do you think children should be when we start to inform them about their diagnosis?
Wouldn't that be very dependent on the child?
Yes, that you know what? That's the best answer. It is very dependent on the child. That is the star answer. I will say less ideal answers are 15, 14, 16, but generally it depends on the child. Because you do want to start the process when they're younger. And so what I've done is I've shown you guys some of the information about guidelines on disclosing HIV status to school-age children. And this means to children under the age of 12. So it should at least give you an idea that the conversation should start well before 12. It doesn't mean that it's finished. It doesn't mean that you walk up to a 6-year-old and be like, hey, so I need to tell you HIV. It's not that at all. But you should start the process, and we'll talk about that in a second, of disclosure early. And so that process should involve the child, obviously, the parents or guardians, as well as members of the healthcare team. So that may be a clinician like me, that may be a social worker, or maybe a therapist. There's a lot of different people that can be involved in this. And as Julie mentioned, it really needs to deal with where they are cognitively and emotionally and maturity wise. You also should make sure that you're involving the parents and caregivers in this, um, as well as sharing the HIV status of the parents and caregivers. Now, why do you think that they put that in there? Well, I can tell you anecdotally, I have had a 20-year-old patient who, at least the last time I saw this person, swore that she got HIV from her father, not from her mother. And what she didn't mean was that her father gave HIV to her mother, who gave it to her. That's not what she meant. She meant that some kind of way she got HIV from her father as an infant. And so it's important to make sure that in the process of disclosure, you're talking about the full process, which can be hard, right? Because that does mean that it's a sensitive conversation about one or more parents or caregivers. Um, and then, who's actually going to do the disclosure, whether it's the parent or caregiver or it's someone from the health team, that depends on the child too. Now, what you will notice, especially if you're research minded, you'll see that the evidence for these strong recommendation, but low quality of evidence, and absent evidence. How many of you all think that there's a way to do a randomized controlled trial on comparing disclosing HIV status at various time points in a child's life compared to disclosing it never, compared to disclosing it at 16? How many of you all think that's a possible study? Yeah, you're right, Dayla. That's not possible. And so part of the challenge with the evidence for this is because it's really hard to study this in a randomized fashion. Yes, Ashlyn. Okay, it went back down. So part of it is you can't study in a randomized fashion. And so while there's low quality of evidence, they do recommend these things because they have seen through case reports as well as prospective and cohort studies what happens when you don't share this information early. So this is a study looking at children within one pediatric clinic in Nashville, Tennessee. And so this is a pediatric HIV clinic, and so that's what they do. That's what they specialize in. And they actually, like most pediatric HIV clinics, they'll see from birth to age 25. So that's why you see this graph being having a range larger than you thought it would be. And at the top, you can see what happened before they started to do their quality improvement project, which was to improve disclosure to their population. What you'll see is that in 2018, when they started their project, the average age or so that people were being disclosed to was at 10 years of age. Right? As far as being undisclosed, I'm sorry, it was 10 years of age. I think I put the same one. But in March of 2020, what you can see is there's significantly less people past the red line, right? If you compare the red line, there's significantly less people that are at the age of 10 that haven't had disclosure. So I said that incorrectly to begin with. I'm sorry. If you look, this red line is where they recommend this for this clinic. They want you to definitely have disclosure by 10. And you can see there's significantly less people after they started their QI project. Now, what was their QI project? Their QI project involved a lot of things. It involved really using this kind of framework that's not important for you to memorize, but using this framework to really understand how to talk about this topic. So for instance, you'll see at the beginning, maybe you have a younger age, right? 6 or 7 years of age. Starting with the parent and caregiver and learning like, hey, so, at some point we're going to start this discussion and this disclosure to this child. What are your concerns about this process? What are things that you have fears about? What are things that you're anticipating? What are things that you're anxious about? Right? Then maybe at a certain stage when the child is a little older or a little bit more mature, you can start even talking about how the immune system works, right? And you're progressing all the way through that to eventually what is HIV, and then eventually what does HIV do, and why are we talking about this with you? And And so you can kind of see through this process, how people actually orient the frameworks. If you go to actually other countries, and right now, again, this is focused on the US, they actually have these amazing booklets and guides to do this, to help do this with pictures. Some clinics here have those as well, but a lot of the disclosures here focus around some kind of framework like this, some kind of discussion. And that's more of that. So, back to our patient, right? They're 11, they're new to us, they just moved to Alabama, they're on 2 pills a day, and we are anticipating that that is gonna become a challenge as they get farther into their adolescent years, so we wanna simplify their regimen. Um, Simplifying their regimen. How many of you would just say, "Go ahead, Samantha, and simplify their regimen"? Nobody? Okay, I like that. I'll take that. It's a thought process, right? Some of the things that go through a clinician's mind about this are, you know, can we do it? So that's an easy one. That's yes or no, and we'll talk about why it might be no. Um, we talk about like if this person stays on this 2-drug regimen and goes through the normal teenage woes, the normal teenage issues, what happens when they decide to stop taking their medicine because they're annoyed at taking a pill? And these are not small pills, you all. These are pretty big pills. These are like multivitamin level pills that do not come in gummy form. What happens if this person finds a partner? So when they get to be 15, 16, 13, I don't know what age they could be, and they find someone that they like and they're cute and they're dating, how does it affect their self-esteem, let alone what happens when they start to be sexually active? Or what happens if this person, instead of maybe finding a partner, also starts deciding to use substances and actually starts experimenting with substances that they have to inject, right? Which means that they may have some partners that they share injection drugs with. All of these things are things that go through our mind as far as when we see someone's regimen to figure out if we can uh, simplify it or not. And so this is a real look at what we call resistance testing for this young person. So this is a real resistance test for a patient. And what I want you to pay attention to is you can see that there are different drug classes. There are these things that you probably know as NRTIs. There are things that you know as NNRTIs. There are things that you may know as protease inhibitors. And then there are things that you know as integrase inhibitors. And if you can see nothing else on the screen, the majority of the medicines that we have in this country, and we do not have Saquanavir in this country, the majority of the medicines that we have in this country, this young person is resistant to. They're not resistant to integrase inhibitors, which is amazing because unlike in the year 1988, or actually the year, let's do 1995, when we only had Zadabudine, this was all that was available in the early 90s. Unlike that, only being available, we now have these integrase inhibitors, and they are super strong in a positive way to where you can start your medicine and reach an undetectable viral load in 1 to 3 months. They're very strong. But guess what? They're paired usually with the medicines in this NRTI class. So when I looked at this young person's medicine, I realized very quickly, I looked at that I need to look at his resistance chart. So I looked at it and I realized I couldn't simplify his regimen because if I did, it might make him resistant to additional medicines. And in his case, it may make him resistant to these integrase inhibitors. And then we have a true problem because then he has resistance in every single class of medicine that we have in the US. So it's something to think about. But if you think about the average young person that's coming in with HIV, whether they're perinatally diagnosed with HIV or they're behaviorally diagnosed with HIV, so through sex or drugs, they actually don't really have a lot of resistance. Most of them have little resistance. And so that's a big, big deal and a big, big difference compared to 40 years ago. All right, our last case, I think. This is a 15-year-old patient that's presenting for a routine health check. They have no other concerns. They are sexually active. They've had one new partner. They request STI testing and have been treated for gonorrhea 4 months ago. They want to be a lawyer. They're an A/B honor roll student at school, and they live with both of their parents and a younger brother. And if you had to think about what you would want to talk to them about as far as health prevention, meaning preventing and making sure that they maintain optimal health, what would you talk to them about? Anybody want to come off mute and say one thing or something?
Using condoms.
I like it, using condoms. Anybody else? All right, we'll go with using condoms. Using condoms is perfect, right? Healthy relationships could be one. Family planning can be one. We're obviously talking about HIV, so using condoms does STIs and HIV. What I want you to know about this case is I specifically did not put a gender in here. I didn't ignore the gender because they're a gender diverse person. That's not what I did. I chose not to put a gender in here because this is a history I see regardless if you are male, female, gender diverse, non-binary. This is a common actual presentation for a new patient for me for either HIV or seeking HIV prevention services. So if nothing else that you learned today, HIV, while it may impact certain genders or races or regions of the country differently, it can impact anybody and everybody. And speaking of, this is from 2022, and I think we all know we live in the South. And so you can see the South as a region accounts for almost half of the diagnoses of HIV. And that number fluctuates. So we're in 2025. That number is not at like 25% today. It is still fluctuating around 50%. Alabama is actually one of 7 states that's been identified by the federal government as having a high rural HIV burden. And so I say that to say, in case you thought HIV was like an urban thing, in the US, yes, there are definitely urban places like Washington, D.C., where HIV rates are high, but there are states like Alabama where HIV is super high in rural areas compared to what it should be. When you look at Alabama here, you'll see prevalence and you'll see incidence. And then you'll see it compared to the South or the Southern region, as well as to the United States. So from a prevalence side, you'll see it's on par with the US, and it's not necessarily the most overburdened place in the South, but again, it has a high rural RURAL burden. But when you look at the diagnoses rate, it, along with the South, have a far higher incidence of HIV. And so this is a state where we definitely want to make sure we're doing our due diligence at preventing HIV. If you look here, and I should say information is always important, and you might be like, Dr. Hill, why can't you separate this out by age? Because that data has been taken down as of almost a month ago. So if you have those questions, I apologize that I don't have the visuals for you. That's why I said save your slides that you've made. You never know when you might need to use the graphics again. But if you look at HIV diagnoses in 2022, you'll see that the populations that are impacted here, you've got different races as well as genders, as well as sexual behaviors in here. And so you'll see that at the top of this one was Hispanic, Latino men who have sex with men, followed by Black or African American men who have sex with men, followed by white men who have sex with men, followed by Black African American women with heterosexual contact, so on and so forth. What you'll see is maybe on the women's side, you'll see the Black African American women are about 3 times higher than their counterparts. And then you'll see the Latino men are almost twice as high as their white counterparts. So there are disparities in here as well. You can look at this. AIDS View is a great resource I would recommend if you're having trouble finding age-related things or whatever demographic you're looking for. You can source this out by state. It's not 100% complete because of the way they gather data, but it's somewhere where you can start. And what you can see is this is HIV prevalence and new diagnoses based on certain demographics. The red color is the actual prevalence in this case over the actual population, and the blue color is the actual incidence over the population. So for Black individuals, they have 63 or almost 64% of the new cases of HIV, even though they account for this very small portion of Alabama's population. And And then if you contrast it, because it's easy to contrast those two because they're easy to see with white Alabamians, their incidence is almost 25%, even though they are closer to 50-60% of the population for Alabama. The same is true when you look down here at the bottom based on transmission status as well. And so you can see the disparities as well. The other thing I want to mention is this idea of an HIV care continuum, in case you haven't heard of that. The idea is to kind of hopefully one day be able to say that of all the people that have HIV, all of them know their diagnosis, all of them are linked to care, all of them are receiving care, and all of them are virally suppressed. That's what we would love to see, with nobody being diagnosed late, which means they're diagnosed with like an AIDS defining illness or advanced HIV. That's what we would love. But as you can see, that's not the case here. And if you look at the population that I serve, which are young people between the 13 to 24 years of age, what you'll see is that only 80% of them are actually linked to care. And that when we get to viral suppression, which is what we ultimately want, less than 60% of them are virally suppressed. And so we're not close to the 100 mark. If we were actually to add a fourth column, because some of these care continuums add a fourth column, which is knowledge of your HIV status. When we talk about 13 to 24-year-olds, only 50 to 60% of 13 to 24-year-olds who have HIV know their status. So let me say that another way. About 40% of 13 to 24-year-olds with HIV do not know their status. And so that's something else to think about. So with that in mind, this is like a study that I did when very early in my career. I was still a fellow. This is a study that probably can be done with most topics. I obviously thought about HIV prevention, but I just wanted to know, in the clinic that I worked, and I worked in a subspecialty clinic with people who love teens, who are trained to teach teens, how many of our teens were being prescribed PrEP? And while you can see the answer, we weren't prescribing any of our teens PrEP. We weren't documenting that we were prescribing any of our teens PrEP. Of the 191 individuals that came in for sexual health visits, so not for their wellness visit, not for a sick visit, but just for sexual health visits within a year span, 44% of them had at least one indication for PrEP. And of those 44% of people, almost half were actually young women. So this was a study, and one of the studies I used way back in the day, I guess, to draw attention to the fact that we need to not forget about young women. All individuals can have it. So if you look at AIDS view and you look at PrEP, and we look at PrEP use versus PrEP need, this idea of the people that are getting HIV, are we able to get PrEP to them? We want PrEP to be for everybody who wants it, but are we also reaching the people who actually need it? And what you'll see, it's the same theme here. The gray bar is the percent of or the proportion of the Alabama population, and then the green bars of varying colors are the actual percent of PrEP users. And you can see 90% of PrEP users in Alabama are male, compared to almost 10% of female or female. You can see that 31% are Black and 64% are white, with 3% being Latino. And what you can see is that for the Hispanic Latino, there's a small gap, as well as for the Black and Latino, meaning they have a higher PrEP to need ratio. They need more PrEP but aren't getting it. And then when you look at the age range, in Alabama, the most common age range to get HIV is actually 25 to 34. They're at 39%, whereas in Alabama, 13 to 24-year-olds account for 16.6%. I can tell you the average for the country is about 20%. So they're a little bit better, which is good. But you can see we need a little bit more PrEP with this age group here. Anywhere where the colored bar is surpassing the gray bar means that we are, I said that wrong. Anywhere where the colored bar is surpassing the gray bar means that we have people using PrEP, which is great. But if we have the colored bar not surpassing the gray bar, that means we need more PrEP in that demographic. So I set out with some people to understand what are the challenges. And because my previous study had actually identified a lot of young women as needing PrEP, I thought I would look to see with a group of people what the challenges were for prescribing PrEP or even recognizing that young women need PrEP. The way that you read this heat map is you can look on the left and you see different reasons that we came up with as far as why providers may be hesitant or unaware of PrEP being for women, or why they're not prescribing PrEP to women. And then what you do is you look at the colors, and if it's orange, that means that this was a significant, was ranked as a significant barrier to a provider thinking about PrEP for young women. Whereas if it's blue, it's not a significant barrier. So for instance, offering PrEP may promote condomless sex. Thank goodness most of the providers still don't hold that view. That's amazing. However, most of the providers were not familiar with options for PrEP for women. Thought that women weren't able to, or young women weren't able to use PrEP, and that it was only for men, and they were not familiar with the current guidelines. And so that was something we had to set out to figure out. I also, because I work with young people and understand that sometimes young people don't have the money, the transportation, or even just the developmental skills to go and seek out these services for themselves. I thought about what would it look like if they were to partner with a parent, an older sibling, auntie, uncle, a coach, or something to get these services, because you can consent to these services as a teenage person. And so I surveyed adults, not young people, but adults, to see if they'd be willing to help them. And the adults actually one, were willing to do so. 94% of them actually believe that young people that are at risk for HIV should take PrEP. And 98% of them were willing to help a young person with PrEP by providing either rides to their appointment, encouraging words, appointments, or even money to pay for rides or the medicine. I then looked at young people and their actual guardian. So I did interviews where I had to recruit a dyad. And so you can imagine that there might be some biases among parents who are willing to let their child participate in this study. But I asked young people and their guardian about what it would look like for them to partner together, right? Because it's easy for me to ask hypothetical questions, but would you be willing to help your child? Would you be willing to go to your parent to access PrEP? And I'm going to read this. This is actually from a triad. This is a dad, and I apologize for some of the language that the dad used. Dad was caught off guard because it was supposed to be mom, and that was participating, and he got called in at the last minute. And then he's got two twin sons. The younger son is sexually active, the older son is not. And so dad says, if one of them, meaning his boys, were taking PrEP and shared with me, I'd have to guard myself. That be just an honest disclosure. Inside, though, it's like, number one, how the hell did you get to the doctor and get this medicine? Because that would have just skipped a lot of steps in an environment that I'm trying to create. Not that I do it right all the time, but I think our kids know our heart and our intention. So I'd be a little set back, but then I would want to begin to say, oh, well, talk to me. I'm glad that you feel that this is going to help you prevent a possible disease in your life. So that's what the dad said. When you asked his sons what they thought about partnering with dad to actually get PrEP, the younger son, who again is sexually active, said, I guess probably a sense of not having to worry as much, because it would be very unfortunate if you have to call up your parents and be like, hey, mom and dad, I'm sorry to report to you, but I got AIDS. That'd be an unfortunate phone call to get. So I think it'd be a sense of relief. Just saying like, hey, you might be having sex, but at least he's being safe. So he wasn't excited about having to ask his dad, but he felt like his parents would be understanding, because at least he didn't come out with an illness that he would require medicine for his life. And then the older son, who's not sexually active, said, which is interesting, I think on the bottom line, it's my choice if I want to take PrEP. I realize that my parents really don't have a say in it. It's my opinion. So he didn't necessarily say whether he'd go to them or not, but he said it's not their business. And so, this provides a little bit of perspective on, would people be willing to actually partner with their parents to get PrEP? We actually did some more studies, and we actually went out and we developed a curriculum to teach family medicine residents, because family medicine residents take care of most of the young people and not young people in the state of Alabama, about taking a sexual history and prescribing PrEP. And we developed what we called PrEP champions, which were particular people that were able to become an extension of our team and do further teaching to their networks about how to prescribe PrEP. That's one of the things we did to address these PrEP prescribing barriers. And then we also have this ongoing study where we're trying to figure out how can we go one step further, and for communities that are under-resourced financially, how can we make sure that they have access to not only PrEP, but PrEP that started the same day, meaning you come in, we obtain your HIV test, but we let you leave with a PrEP prescription. And so we're doing that. And that study is not only in Alabama, but it's also in Texas and Illinois. And it's a multi-site study among community-based organizations and federally qualified health centers. The last thing I'll mention is that we have an ongoing study really trying to figure out if we can use technology to help increase young people using PrEP. We are trying to see if we can pair young people with an adult person through an app, like an adult person they know, through an app, and see if using the app can build their sexual health knowledge, their relational health knowledge, their HIV prevention knowledge, their HIV knowledge, and their PrEP knowledge, as well as increase their desire to use PrEP. And we have been working on that for the next several years. Please pray that the funding does not go away. So in summary, a lot has changed in HIV over the last 40 years. We have amazing medicine, and even though pediatric HIV is super broad, as in children with HIV and adolescents and young adults with HIV, and infants with HIV, they all have their own challenges, but you can do a lot of collaborations to actually work on eliminating perinatal HIV transmission, which we're still working on. You can do a lot of collaborations to make sure that children with HIV are actually disclosed to appropriately in an age-appropriate and developmentally appropriate manner. There's more work to be done on that. And then there's a lot of work that still needs to be done to prevent HIV, particularly behaviorally acquired HIV among adolescents and young adults who are really still unaware and unsure of the medicine. And so that's my brief summary of how things have changed based on what I see clinically and what we do as far as research. And I'll stop there.
Thank you, Dr. Hill. We've got a couple minutes left. If anyone wants to unmute themselves and ask a question or put a question in the chat box, now's your chance.
And thank you, Ashlyn, for putting AIDS View in the thing. Is anybody, oh, go ahead, Brian?
Yes, that's brilliant. Yes, thank you. That's a nice presentation. I've enjoyed it. My question, I was seeing that bar graph about incidences of HIV among children starting from 0 age groups. I understand those from 0 to 5, most likely maybe from mother to child transmissions. What would be the most common cause for those kids after the age of like maybe 5? And why I'm asking this question is there cases where children are born with HIV and they remain undiagnosed and live with HIV up to older age? What would actually help them to keep that healthy or immunity until that age before they are diagnosed? That's my question. Thank you.
Yeah, that's a great question. In the US, we and I this is globally too, but in the US, we do have some young people that go undiagnosed. So the ideal situation is the person gives birth to the child is linked to somebody who can follow them and monitor their labs, as well as weight adjust their medication to make sure that they do not acquire HIV. For the young people after 5 months of age or so that acquire HIV, a lot of that is they got lost to follow up. So an example will be, I had a mom that I actually had to go get from community. The place where she gave birth that told her go follow up with us, but didn't provide her instructions. She reached out to a number. The number is like, we don't do that. And so she went about her day, not because she wasn't worried about her child and whatever, but she didn't know what else to do. Some kind of way that child got to us and we found them, and that child's fine. But people get lost in the system a lot. I've had another patient, and I met her when she was in her 20s. She got diagnosed at 8 years of age. She's perinatally infected with HIV from her mom. And she only got diagnosed because a neighbor happened to see her when she was looking really sick, and the neighbor called 911. And as part of the workup for her at 8 years of age, they found out that she had HIV. And her mom said, yeah, that makes sense because I have HIV. So we do see, or actually her mom had advanced HIV. So we do see people that get lost in the system, especially let's say you're pregnant and you're moving from one hospital system or state or country to another. We see that all the time. And so that's probably the biggest barrier. We do have some people who are linked to care who get lost to follow up, meaning they come for a couple of visits, but they don't complete their visits. And or they don't actually remain adherent to their medicine and they become non-adherent. We have those kind of individuals. And then unfortunately, there's a very small, like well less than 1% of people that can actually seroconvert from negative to positive around like 18 months or so. That's a small number.
Yeah, thank you. I actually understand. Thank you so much. Maybe others if they have questions.
I also have a question because I'm thinking about where you're located as a physician in Alabama, and how HIV, especially in communities of color, international communities, and things like that, this is a very heavily stigmatized disease, has a lot of false nuances. A lot of people don't really understand it. It's viewed a very certain way, especially within South and these communities that I've talked about. So as a physician, how do you kind of deal and address those preconceptions that a lot of people have? And then also countering on the physician side, Alabama is located within the Bible Belt, and I imagine a lot of physicians also bring their personal biases, religious biases, and things like that into the workplace. How do you find that I guess influences how things such as PrEP are recommended and distributed to patients?
Yeah, it's a great question. Those are both great questions. So the first question, what I start with is I have to remind myself, I'm all about like radical love and empathy. And so I run into people all the time who have whatever preconceived notion that may be incorrect about HIV. And what I do, and what a lot of us in this field do, is we create space to have open dialogue so you can ask those questions in a safe space. And we gradually provide the information with you. We also, I know I personally offer, like, if they brought someone, particularly if they're a teenager or a young adult, we see them by themselves. So if they brought someone, once I've done the clinical visit, I'm like, is there someone with you? That you want to have a discussion with? Or let's bring your parent. Maybe there's a parent that doesn't know. Let's bring the parent and have a discussion together about what this means. So that's one way we do it. I have actually had to dismiss only once a parent from clinic before. And that was a situation in which they had a young person that was diagnosed, and they had to put all of your things together because of their particular faith background, and the young person's not only HIV diagnosis, but the young person's sexuality. They were really struggling. And struggling is okay. Let me make sure I emphasize that and say it again. Struggling is okay. That's part of life. It's a diagnosis, like you said, that people struggle with. But they were using words and terms out loud in front of the young person who's newly diagnosed, and were disclosing that young person's status and all of their statuses to the family member. So for instance, it was around Thanksgiving and they were like, well, I just let the whole family know that we can't come because we can't share food and forks with him because he's got HIV. It's important that they know he's got HIV. So like that kind of level of thing. And she's doing it in front of the young person. What we do with those kind of things is we usually start off with, if there is a faith or a cultural background, finding a chaplain or someone that's able to speak to that person's cultural background. We did that for this parent. That was a fail. Unfortunately, the chaplain was like, I'm happy to keep talking with her, but she's not at all in a receptive space. And so that's when I had a discussion with that parent of like, hey, let's do this. I can't have you come to clinic anymore because you are endangering the therapeutic environment that we're in for this young person. But what I can do is I can call you after clinic and hear your concerns. I saw you had a question real quick before I answered your second one.
Oh, no, I didn't. I was just listening. I accidentally turned on my mic.
Yes. And then, so for your other question about, how do people's particular biases get in the way of PrEP? It's a great question. I look young, but part of the reason I'm in HIV is because I was born in the 80s, and so was very familiar with HIV. But a lot of us that trained back then, there's this idea of, I'm a doctor, sure, or whatever kind of health professional that you are. Um, and maybe something's against my particular background or belief system, but let me refer you to someone who can actually do that. So a more common example is abortion. I'm an OB. I don't believe in abortion. Like if that's your situation, right? I don't believe in abortion, but let me refer you to someone who does. As an example, that's not the case, is what I'm finding all the time in medical education today. And so your question is super valid because um, you might come across a provider that not only doesn't believe in maybe PrEP, but isn't willing to actually refer you to someone who can provide those services. So the way in which a lot of us approach that is there's a lot of empowerment building in medicine now. Those of us that work with young people in general, regardless of HIV status, we are all about empowerment. And so I always empower my young people or their parents to be like, let's find a second opinion. Let me give you a list of providers so that you have multiple options. Even if like I asked Julie to give me the best doctor she's got, she's like, I can only give you one. I'm going to create an additional list because I think it's important for them to have choice in who they see. And so that's kind of how we tackle that, because outside of that, it's back to getting into that creation of a safe space to see if that provider or that healthcare system is willing to engage in a conversation about health and understanding humans are human, right? And while they may also share your beliefs, they may not be able to automatically control their mind to do those behaviors like like that. So I hope that answers your question.
Yes, it did. Thank you very much.
And I hate to cut this short, but it is 7:06, and I want to be mindful of how long we said the seminar would go and people's schedules this evening. Thank you, Dr. Hill, for this presentation. If you've got any questions that you would like forwarded on to Dr. Hill, I know you had your email address up there for a little bit, but it wasn't up there for long. It will be included on the archive, so you can get it off of that too. But if you want to relay some questions to her in between now and then, just send them to me and I'll send them on to her and we'll get those answered for you. And I want to thank everyone for joining us tonight.
Thank you all. Thank you, Julie, for having me. Thank you, Ashlyn.